All right, if you're gearing up for your anesthesia finals, you are in the right place. We're about to do a high-yield deep dive into the perioperative management of pancreas transplants. We'll be breaking down the absolute must-know points from a key BJ education article to give you that critical edge.
So to really get why this matters, let's just start with this number, 463 million. That's the number of adults around the world living with diabetes. For those with the most severe forms, a pancreas transplant isn't just a treatment, it's the only cure. And managing these incredibly complex patients, well, that puts us, as anesthetists, right at the heart of their survival. So here's our game plan. We're going to walk through the entire journey, step by step. First, we'll cover why we do these transplants in the first place. Then, we'll get into the weeds on the preoperative assessment of these very complex patients, lay out our intraoperative strategy, talk about that crucial postoperative period, the complications we have to be on the lookout for, and finally, wrap up with the outcomes we're all working towards.
Okay, so what's the fundamental reason for this procedure? Well, a pancreas transplant is for patients with insulin-dependent diabetes mellitus. It's the only thing that offers a potential cure, moving them beyond a lifetime of insulin management. And there are three main ways we go about it. The most common procedure by a long shot, we're talking over 3/4 of all cases, is the simultaneous pancreas kidney, or SPK transplant. This is for the patient whose long-standing diabetes has completely wrecked their kidneys, leading to irreversible failure. And the benefit here is huge. An SPK transplant can lead to a 30% reduction in mortality compared to just staying on dialysis. It's a game changer. Next up, you've got the pancreas after kidney, or PAK transplant. Pretty much what it sounds like. This is for a patient who's already had a kidney and is now coming back to get a pancreas to finally treat the root cause, their diabetes. And finally, there's the pancreas transplant alone, or PTA. This is for a smaller group of patients whose kidneys are actually still working fine, but they suffer from just awful metabolic complications, things like life-threatening hypoglycemia unawareness that just can't be controlled with normal insulin therapy. Okay, so now we know why we do the transplant. Let's shift our focus to who we're treating. And let me tell you, these are some of the most medically challenging patients you'll ever encounter. That makes the preoperative assessment absolutely critical to getting a good outcome. So what is it that makes them so tough to manage? Well, it really all boils down to the widespread damage that years and years of poorly controlled diabetes does to the entire body. Let's just break it down system by system. Cardiovascularly, they've got accelerated atherosclerosis, and coronary artery disease is 4 times more common, often without any symptoms. Neurologically, you're dealing with autonomic neuropathy, which means their hemodynamics can be wildly unstable. For the airway, stiff joint syndrome can make intubation a nightmare. And gastrointestinally, diabetic gastroparesis puts them at a huge risk for aspiration when you put them to sleep. So, because of all that, our preoperative workup needs to be incredibly thorough. We're checking their long-term sugar control with an HbA1c. For the heart, we're doing a 12-lead ECG and often a dobutamine stress echo to find that silent ischemia. We're specifically looking for autonomic issues by checking for orthostatic hypotension. A really careful airway exam is a must. And finally, we're checking their coagulation status because these patients are often hypercoagulable. All right, the patient has been cleared, we've done our homework, and we are heading into the operating room. Now, let's map out our intraoperative strategy, where pretty much every move we make has a direct effect on whether that new graft survives. I like to think about the anaesthetic journey here in 5 key steps. First, induction, where you have to think about a rapid sequence technique for gastroparesis. Second, monitoring. It's got to be invasive. Third, maintenance, where hemodynamic stability is the name of the game. Fourth, fluids, a super careful balancing act. And finally, step 5, reperfusion, that critical moment where you have to expect things to get rocky. In this quote from the source article really drives home a point that is absolutely non-negotiable. With the autonomic neuropathy and huge fluid shifts, hemodynamic instability isn't just a risk, it's an expectation. That's why invasive monitoring, especially an arterial line for beat-to-beat blood pressure and frequent blood gases, is essential. Now let's talk about fluids because this is a really important decision point. You could use normal saline, which avoids potassium, but pouring in large volumes can cause a hyperchloremic acidosis, which is bad news for the new kidney. That's why balanced crystalloid solutions are usually the better choice. They help the acid-base profile and seem to be better for kidney function, even though they have a little bit of potassium. And our hemodynamic targets? They're not just random numbers. They're based on evidence. This data is pretty clear. A MAP below 70 and a CVP below 8 was linked to delayed graft function. Why?
You have to remember, the pancreas is a low-flow, low-pressure organ, so it's incredibly sensitive to hypoperfusion and thrombosis. On the flip side, a MAP above 91 and a CVP above 12 was associated with the graft working right away. Our job is to keep that perfusion robust. And now, the moment of truth. Reperfusion. The second those vascular cramps come off, the insulin infusion is stopped, the new pancreas is officially on the clock. It's our job to check its work with frequent glucose checks, every 5 to 15 minutes at first, and carefully giving dextrose if needed to make sure the patient doesn't get hypoglycemic while the new organ is warming up. The surgery is over, but our job? Oh, it is far from done. The patient is headed to the ICU, and those first 72 hours are absolutely critical for the graft's survival. Postoperative vigilance is everything. In the ICU, that same level of vigilance just continues. We're talking hourly glucose checks for at least the first 24 hours. We're watching electrolytes like a hawk, especially potassium. We are still aggressively keeping their blood pressure normal to protect those delicate anastomoses. And we're using multimodal, opioid-sparing pain control to get them moving and reduce other complications. And here is a massive red flag for your exams. If this patient, who should now be making their own insulin, suddenly starts needing it from an external source again, that is a huge warning sign. It tells you the allograft, the new organ, is in trouble, and it could be the very first sign of the most dreaded complication. That warning sign often points to one thing, the most feared early complication of this entire surgery, and we are talking about thrombosis of the new graft. Let me be perfectly clear. Graft thrombosis is the #1 technical reason for early graft loss. It usually happens within the first 48 hours, and venous thrombosis is about 3 times more common than arterial. And you need to remember this number. Over 70% of early graft failures are not due to immune rejection. They're due to a technical failure, and that is almost always thrombosis. This is exactly why the surgery has to be perfect, why our hemodynamic management is so intense, and why these patients are often on heparin infusions after the surgery. Okay, after talking about all those risks, let's finish up on a really positive note by looking at the results. Because when everything goes right, a pancreas transplant is an incredibly successful operation. I mean, just look at the outcomes for SPK transplants. They are excellent. Patient survival is nearly 90% at 5 years and still 76% at 10 years. Those numbers are really a testament to how far we've come in surgery, immunosuppression, and of course in our perioperative anesthesia care. By the way, all the key points we've hit on today are laid out in a fantastic 2023 article by Ulla and colleagues in BJA Education. It is an absolute must-read if you want to dig deeper into this topic. And that brings us to one last question to think about. With patient survival this high, what's the next frontier? How do we go beyond just survival and improve the long-term function of the graft and, importantly, the quality of life for these patients? That right there is the challenge for the next generation.